I hope we will get to as many questions as possible. I'm going to start with a few, and these questions are open to all of our faculty. And I'll start with a newly diagnosed patient. When a patient is first diagnosed, does the specialist typically already know if this patient will be a candidate for transplant, or do they have to wait and see how they respond to the first line of therapy before deciding?
I can take that question. You know, sometimes it's very evident. You know, if you are, 55 and you come in with minimal symptoms, you have no other medical problem, you clearly are. If you are 83 with diabetes and heart failure and 2 prior strokes, you clearly are not. Most cases are not so clear. And it's important that the patients insist in seeing a specialist that does stem cell transplant. Sometimes the initial physician who is managing that patient is not a transplant physician and might not have the right appraisal of who is or who is not a candidate for transplant. It's also important to not make that determination based on how the patient first presents with all the signs and symptoms of myeloma. I have seen many patients who, present, wheelchair bound with fractures and pain, and they can't even dress themselves independently. And, and 3 months later, once you treat the disease, manage the symptoms, they're in a much better situation and can understand the transplant. So the physician should work with the patient, choose the best available regimen for that patient, give the benefit of the doubt, and it's important that the patients seek the input of a physician who has firsthand experience with transplant.
Could I just add just a couple of comments to what Dr. Costa said? Certainly the bone pain, we all have seen that. We've also seen people who've had terrible kidney function within a couple of cycles of therapy go to completely normal kidney function. That makes a difference. And obviously we all here are people very interested in myeloma. I do think that as this treatment and decision-making gets somewhat more complicated, at some point I think it is helpful for people to see perhaps a individual who has some expertise in myeloma, particularly if, as Dr. Costa said, somebody says, absolutely not this or absolutely not that. There's a lot of nuance here. And I think there's actually some data that seeing some people who have some background and some expertise in myeloma actually helps you do better in the long run. And so I think it is really important to help in that kind of decision making.
Let me just emphasize that point, because there is data from the Mayo Clinic and also from the University of North Carolina that shows that patients who go and see a myeloma expert they live longer. So absolutely, as a patient advocate myself, you need to go see a myeloma specialist. You need to have that person on your team. You can get care at home with a local person and get all your infusions locally. Absolutely. But as you're seeing, there's a incredible level of nuanced care in myeloma, and you really need to have that expertise in your corner. So that's my little plug, because I'm huge on that.
Yeah, I think the one thing that I want to add on is even for patients with kidney dysfunction, let's say they presented with the kidney dysfunction initially, and then, unfortunately, sometimes they don't get better. Those patients also can go to transplant with a dose-adjusted melphalan, and then I have seen sometimes these patients get the kidney recovery even after transplant.
Absolutely. So yeah, we've had patients too who have been on dialysis at the time they have the transplant, and then a month or two later they're off. So.
And that question was from Barbara. I failed to ask that. I mentioned that before. This is from an anonymous viewer. Does having an MGUS diagnosis mean the immune system is more at risk? And what are doctors looking at in the lab work?
Well, I can start with that, and anybody else can chime in too. There's more and more research being done in MGUS. When you look at large population studies, there is some discussion about whether this is really a benign finding. And if there does seem to be, this is work that coming from Dr. Robert Kyle, who's really been a pioneer. He's still in practice at Mayo Clinic, but he's looked at thousands and thousands of records of patients with MGUS. And in age-adjusted populations, it does seem to be that there's a little bit of a lower survival for people who have MGUS, and it's not really clear why exactly. So we know that there is a higher risk of developing not just myeloma, but disorders like chronic lymphocytic leukemia and lymphoma. There's been some higher incidences of other autoimmune disorders. So we do believe that people who have a diagnosis of MGUS need to be followed, not necessarily that often if they have very low levels. And then I'm sure Dr. Zonder is going to cover this afternoon. It's very, very critical that people who have MGUS are screened for amyloidosis.
We have two questions that are.
I will 100% cover that this afternoon. I could unmute there, but yes, I will cover that. Yes.
Thank you. This one, and I apologize if I get the name pronounced wrong. I have a question from Shasta, and Thomas also submitted a similar question. So Thomas, excuse me, I got that mixed up. So Thomas asks, we're told that we are immunocompromised category. What exactly do we measure? How exactly do we measure our immune system? To put it another way, exactly which blood tests and myeloma markers can we monitor to know just how immunocompromised we are?
So I got that question asked a lot. I'm sure my colleagues on the panel have the same experience. And what I tell my patients is, it's not a single number, it's not a single parameter. There are many. One that often patients and we pay attention to is the number of neutrophils in the blood, which in most part, except for a couple weeks after transplant, that number is usually pretty normal. The other parameters are the immunoglobulin levels, the level of normal antibodies, that tends to be lower in patients with myeloma, and is sometimes driven lower by the therapies. The most important thing, however, is not all about the numbers. I like to tell the patients is, sometimes you can have a perfectly well-sized army, but they're not well-trained. So there's this concept of the function of those cells, those lymphocytes or neutrophils, and the immunoglobulin that cannot be easily measured. And the disease itself, independent of any therapy, is on itself immunocompromised. So unfortunately, the answer is multifactorial and very complicated.
And I just want to add, one of the big culprits we know from history in our myeloma regimens, and one of the reasons that the amount of this is going down is steroids. And so there was an era when we sort of thought the more steroids, the better. And it's true that if a person needs a very quick response in their myeloma, you can use steroids to help get them down. But if you leave people on high doses of steroids, it clearly increases a risk of infection and in some studies in death. So we try to limit that drug as much as we can. I know it's everybody's least favorite drug. So that's another factor, not just sort of antibody levels too, but what drugs you're getting.
Yeah, I think that's a crucial point. I would say, I always ask your doctor, can my steroid go down? Sometimes we keep the steroid going while, for many regimens after a certain number of cycles, discontinue or lower the dose of steroid had no negative impact on your myeloma control and can make it safer. Sorry, I think I interrupt Dr. DeCall.
No, I think I've just emphasized on that point. And the other point is, like IgG level, we always measure and then try to give IVIG. So my patients always ask, can I get IVIG? Or that kind of thing always come up. So sometimes the patient have high IgG level because of myeloma and still they're not protected. And so the question is, like, you have to do a case by case, basis in that. Even though you have a high IgG level because of myeloma, they're not functional, as you just pointed out, and they may not be working. So we have to look at that factor as well.
And then I have one more question, and I'll pass it over to Jenny. This question is from Shasta. How do you identify non-secretory myeloma, and how do you track it?
I can take that. So the non-secretory myeloma means before we had this free light chain assay, and that used to be about 10%. But now with the with the availability of free light chain assay, we have about less than 5% of the cases. So non-secretory means your plasma cells are not secreting any of the protein, whether a light chain or the complete monoclonal protein, and that's what we cannot detect in the blood. But they are there and causing the bone damage and all those stuff. So the best way to identify this non-secretory myeloma is one is by doing a bone marrow biopsy, but more importantly by the non-invasive ways by doing a PET scan, more sensitive scan, either a PET scan or MRI. Now, to monitoring this, since we rely on monitoring with the blood work for our myeloma patients because they are secreting the protein and just rely on the measurement of the protein level. So monitoring is challenging in the non-secretory myeloma, and we just rely on the imaging and or bone marrow biopsy to monitor the treatment response and to how they are doing, whether they're relapsing or whatnot. Now, unfortunately, one of the parts that I have to mention is that these patients are always excluded from the clinical trials because they have no measurable disease. But now the trials, I think the newer trials are coming up, they are including these patients as well, including the patients with the measurable plasmacytomas or measurable bone disease, and including these patients in the clinical trial.
Jenny?
Okay, great. So we had some questions also from Adrian and Steve about daratumumab use, especially in the COVID scenario. If you are not taking it now, should you start it in relevance to COVID? And if you're on it, is there any additional risk?
Okay, I just want to say, you know, I would be interested what my colleagues would say. You know, this comes up a lot with patients, like, should I be on chemo? There are many situations when by far the biggest threat to you in the immediate future is your myeloma. And I think, we need to make sure that you get the therapy that you need in the timing that you need it. You know, if you're talking about, adding it in, say, for a maintenance program or something like that, there's some discretion. But I think we would all agree that we do not want to inhibit people from getting the right treatment because of concerns about the virus. And I'll defer to my colleagues here.
I totally agree. This really, I find interesting that this discussion has really put the monoclonal antibodies, particularly daratumumab, on the spot. It is true that when you look at randomized trials, trials where half the patients got daratumumab and half the patients didn't, there was some increase in risk of respiratory infections on daratumumab, mostly upper respiratory infection. The matter of the fact is any myeloma, any drug that treats myeloma will cause inhibition of production of the normal immunoglobulins. There is just no way around. And daratumumab being a very potent drug, it has that very potent effect. The key point here is if your doctor is recommending daratumumab, is because at that particular point, that is important treatment for you. That's the one that's most indicated for your myeloma. As Dr. Callender said, the risk of getting suboptimal therapy greatly exceeds the theoretical risk of having a worse complication because you are on daratumumab. There is really no data that I am aware of the patients on daratumumab that acquire COVID have a worse outcome than patients who are on other therapies for multiple myeloma. The other point I was going to make is if you are already on therapy, the effect is already established. The daratumumab stays in your system for several weeks. So, skipping a dose or two is not going to necessarily make you any safer. If anything, you are essentially compromising your therapy potentially without really any improvement in your immunity. So talk to your doctor, do what is best for your myeloma, and don't let the fear of COVID get in the way of you getting with the treatment that is best for you.
Okay, another question related to that, but stem cell transplant oriented, is from Jim. and his May stem cell transplant was suspended. And so he's wanting to see things with COVID get under control. No detectable disease at the moment on RVD, Rev, Velcade, Dex. What do you suggest for these types of patients? Because you're still, as you said before, doing stem cell transplants in your facilities. But I think his concern is my immune system post-transplant, not necessarily just the transplant process.
The first thing I would like to know is what is the risk of his disease? You know, if you'd like to talk to a doctor, what if he's a high risk, you know, if it's a standard risk. And as we just discussed, like transplant is still very important therapy for myeloma patients to control the disease for long term and to get a deep response. So if the risk is very high, then definitely I would go for a transplant because the benefits that outweigh that. And if the disease risk is not that, it's a standard risk, it's a favorable risk, then I think it has to be discussed with the doctor, the pros and cons of you know, delaying by a month or so. But still, I would like to go for early transplant. It's just a matter of where you are and how the surge in that center and how the surge in that region. You know, so that has to be discussed actually.
Mm-hmm. Okay, another question from Jody, whose dad was diagnosed and is going to a VA hospital. He had a collapse in a vertebrae. Has been on therapy for 2 months with probably KRD. It says KBD, but I think probably KRD. And just wondering if that's the right therapy if they're seeing this collapse, but that probably happened before, right? So,
yeah, let me start with that too. What sometimes happens, not infrequently, is that, you know, people come in with sort of a certain amount of bone disease, and they will have some structural abnormalities. And one of the areas that we are really still lagging in myeloma is we don't know how to restore bone. So that it's not uncommon that you'll have a person who has, you know, sort of a shelled out vertebral body. They're getting effective therapy, they're clearly responding, but regardless, they have another fracture of a vertebra right in the middle of therapy. And that doesn't mean that things have failed. Of course, you should look at that and make sure that there's no question, but it's not an uncommon thing to happen. And I think everybody here in the panel would say that is one area that we need some better interventions. We just don't know how to grow new bone at this point for people.
I totally agree. The other thing that I would add is, you know, sometimes patients have a diagnosed one modality of radiologic assessment for bones, for example, X-rays. And then, you know, you start treatment 2 months in, my back is too hurt, then you do an MRI, and then you see a lot of lesions that you didn't know you had. And then that gets read out as being new, and people panic. Well, you know, sometimes it's a new finding, a new discovery, but it's not a lesion that is new. So I'll be very careful in interpreting lesions on an area that has not been imaged before with the same modality.
okay, great. So we talked a little bit about we have 2 questions about causes of myeloma, and I don't think there's a lot of data there, but maybe you want to address it. So Robert was wondering about like heavy metal exposure when he was young, and then Mitchell was wondering about Agent Orange exposure. Do you want to address those 2 potential causes of myeloma?
Well, I think so. So what happened with Agent Orange exposure is in 1991, the Institutes of Medicine went through all the data and felt that there was a preponderance of evidence that linked a higher than expected incidence of a number of illnesses. Multiple myeloma was one of them. But it is clear that not every single person who was exposed to Agent Orange got myeloma or got other illnesses. And one theory about myeloma propagation is that the Agent Orange herbicide was contaminated with a chemical called dioxin. And dioxin has a very, very long half-life. And it can, there's actually was a study done where you could find traces of dioxin many years later in people who are exposed to this. So that chemical dioxin has been used in the lab to cause mutations in cells that could lead to cancer. So that's one theory. You know, in terms of other environmental exposures, I'm sure everybody here knows it's incredibly difficult to prove that, you know, one individual's exposure is what led to their cancer. You can sort of say in aggregate, like, you know, cigarette smoking, we've got tons of epidemiology that links that. But in any one individual, we really don't have the science yet to say, okay, that's what caused your cancer. So we look often at sort of associations.
Yeah, I think I agree. I always tell, that is the most common question that my patients always ask me, what caused? I was working in this factory, I was working this, and is that the cause of the myeloma? But I tell them there is no any strong epidemiological studies that have been done that pinpoint this is the most important risk factor, like we have for smoking and lung cancer. We don't have that. So it's probably multifactorial, and a lot of things are associated, but there is no strong causation of any of the risk factor.
Mm-hmm. Okay, great. We have an anonymous question also, and I think this is appropriate for a brand new, newly diagnosed patient that came in, female, age 52. She had bone breaks that made her discover the disease. She's trying to, well, first, she has a question about staging because it was classified as stage 1. And I think someone needs to address staging in multiple myeloma and how that's not similar to other types of staging in other cancers. But she's also just kind of wondering, treatment option wise, is it worth going through all the treatment? I think you have to weigh that as a patient. Like what's the benefit versus the effort that I'm going to in all these treatments versus like just a palliative care. I think we need to share the hope of what's available in myeloma for someone who is basically newly diagnosed. And then she also wonders if the chemo can prevent more broken bones and more bone pain.
I can actually, first, in my talk about amyloidosis, I'm going to specifically talk about staging of myeloma versus amyloidosis versus other cancers. So I'll cover that. But the short answer, to that last part is that it is very, very clear that effective myeloma therapy itself is one of the most effective means of preventing future skeletal complications. We use specific agents like denosumab or zoledronic acid, and we know that the use of those, regardless of myeloma response, does have an impact on reducing skeletal complications. But we also know overall that skeletal complications now generally aren't the same as they were, years ago when the original, bisphosphonate studies with pamidronate and zoledronic acid were being done. We get much better myeloma control now. And so, just the baseline rate of skeletal complications that you are trying to impact with those drugs actually seems lower now than it was in the past.
And in terms of staging, I think Dr. Jondre is going to cover, but I just want to add one or two lines on that. It is evolving because we used to have one stage, now it's changing. And now it's, of course, for the betterment of the, refining this process, but it is not the same as the other solid cancer. That's why I tell my patients, it just measures the disease burden and plus minus some of the disease risk. But as compared to somebody who has a lung cancer and then get a stage, that is the huge difference, because right now, as of now, the treatment is pretty much the same for all the stages in myeloma. So that's why I focus on that part too.
I just also want to just focus on the hope part of this. I think, this is an excellent question from whoever asked it. Just because you have 10 vertebral body fractures, you can have stage 1 myeloma, unfortunately. I mean, it seems like that shouldn't be true, but it is. But I think every one of us here knows well that you can see people who are, not able to walk, barely able to move. And a year later, after good therapy, and maybe that's a transplant or maybe not, for a 52-year-old, people are back to a very good quality of life. They're back to work, they're back exercising, they're back traveling. Obviously not right now, but I think there's every reason for a person to say, you should hang in there. It's hard. It often takes months for people to get their bone pain under control. But as Dr. Zonder said, effective therapy is the key to getting people better. And it's, I think every one of us, again, has had the person come back 6 months after a transplant and say, this is the best I've ever felt. This is the best I've felt in 2 or 3 years. I'm able to do so much more. I'm back to my life again. And I think that's something that you have to keep hold of.
Yeah, I completely agree. Cynthia asked a question about being newly diagnosed, and now she's on Ninlaro Dex as maintenance. And being new to it, I think newly diagnosed patients don't understand How long do I stay on maintenance for, you know, is it forever? How do I manage this?
So I can talk a little bit about that. So the data is, of course, as everything in myeloma, evolving rapidly. The main recommendation we have in the United States is for the average patient, you stay on maintenance until the myeloma gets worse, or you have some problems that cause you to discontinue the therapy. The question of what the optimal duration is still to be answered. There's a trial that we should soon learn the result performed by the ECOG group that randomized patients between 2 years of maintenance versus maintenance until progression. And I think in the future, future trials like the SWOG 1803, that's really going to try to answer the question according to the depth of response, essentially randomize patients who become MRD negative to continue therapy versus discontinue therapy. This patient is on 2 agents for maintenance, which implies that probably that patient was perceived as having high-risk disease. And on those patients, I think most of us would continue maintenance until progression.
And then you may want to ask your doctor why the doublet for maintenance therapy as well. Yeah. So, just so you learn more about your own myeloma. Okay, there was another question talking about what you talked about earlier in terms of how you define somebody who is more immunocompromised. So Robert has low neutrophil and white blood cell count and is looking to boost it, lowered the dose of Revlimid because of it, 4 months post a year of KRD therapy, and looking for guidance just on other causes of low immunity, but stable disease. What else could be causing the low count?
So is the question that he is hesitant about lowering Revlimid for low counts? Or?
No, he did lower Revlimid, and just wondering what else is contributing to the low neutrophil white blood cell count.
Well, I think that is clearly the most common side effect one sees with Revlimid in maintenance is lower blood counts. And I think, to reassure him, there's very little evidence that the success of the maintenance is dependent upon dose. I think you definitely, for long-term therapy, you want to make sure that a person does have an adequate neutrophil count. Most studies will have that at sort of set the bar at about 1,000 for neutrophils and typically around 50,000 for platelets. I think one little note of caution is if a person has been on Revlimid and their counts suddenly become very low and do not get better once the drug is held for several weeks, I think that requires some additional investigation. That can be a different problem.
I agree, and I would add that an average patient on Revlimid has counts that are lower than normal, and there's a difference between being lower than normal and being riskily low. There's a very wide difference between the lower limit of normal and the level that we consider puts patient at risk for infection. So sometimes patients get concerned that, while my neutrophil was, 2,500, now is 1,200. That's great. That's fine. That's an acceptable level. There's no data that you are at a high risk of infection at 1,200 than you are at 2,000. And that should not be a reason to reduce or to adjust the dose. If it gets below 1,000, oftentimes we do adjust the dose. But don't expect normal. I like to tell my patients and teach the trainees that a blood count of a patient on Revlimid is about 80% of normal. So we should accept everything as being a little bit lower.
Jennifer asked the question, what are the best ways to improve physical fitness during and after treatment, and is weight training beneficial or dangerous?
I'll take that. I mean, there may be a broad, spectrum of opinion about this matter, but the issues, I think I encourage exercise for my patients, aerobic type exercise if they can do it. I counsel them to avoid higher risk behaviors. There's certain kinds of sports and exercises that aren't as safe as others. Weights is a common question. And my advice is first consult with your myeloma specialist, who probably has a better idea about your bone disease than anybody else does, because that's kind of the key. And I counsel my patients with spinal disease that lots of reps with low weight is much better and much safer for them than heavy weights. And I really specifically caution patients against loading weight above their shoulders, which pushes, a lot of downward extra force on a spine that may already be at risk of compression fractures. I'd be curious to know what other people say.
Yeah, I don't think we encourage exercise enough. There was a very interesting study published a couple of years ago about 25 patients who were actually encouraged to exercise during their transplants, and they ended up having a lower rate of infection and a shorter time in the hospital. So, most people can do some sort of low impact exercise, whether that's walking or a stationary bicycle. And I usually try to get people to do that as soon as they can. There are some people who are coming into this who are already sort of elite athletes, and they are interested in getting back to what they knew and loved. I know from our orthopedic surgeons, I think the one activity that they are very cautious about, and for reasons about just sort of weight bearing, is running. And so I have some patients who are able to go back and run again. Those are people who either are far out from their initial diagnosis. I usually tell them to be incredibly cautious. I mean, and sometimes we have them do a run walk routine. That's clearly the minority of people, but I would echo what Dr. Zonder said. I think we underprescribe light weights. I think that's actually been shown to help prevent bone loss in osteoporosis and improve balance and actually improve mental status in people who are older too. So I think light weights are probably something that we should consider doing, but it's going to be a gradual thing. So again, if somebody's rolling in a wheelchair on crutches, we're not going to say, okay, go out there and walk an hour. But I have often told people who are able to do so, start with a couple of minutes on a treadmill. If you can do it, you can start building up. Do it on an incline, do it at a slow rate. So
what I tell patients without any data, but just common sense, is if you have access to a swimming pool, go swimming. Excellent cardiovascular exercise and very easy on your joints and certainly on your spine. And it's a good way to get back into activity.
Okay, great. So there have been several questions about stem cell transplant. What is early versus delayed? Can you clarify that again? Laurent had that question. Tom was wondering if you had a moderate response to your first transplant, should you get a second one, and at what time? So somebody can address maybe time frames of or remission durations. And then Scott was also wondering, he collected enough for 2 stem cells. When should he at some point consider a second?
So the early versus delayed is basically, when you look at early, is when you're diagnosed and the very brief period of induction and then go for a transplant. Then delayed means when you're transplant, you don't get transplant until you have a first relapse. So that's how the study is designed, early versus delayed. It's not based on the time. If you look at the early transplant, most of the patient will get transplant within a year or less than that. But the term definition of early versus delayed is basically when you are first relapsing. If you are first relapsing, getting a transplant, there is a delayed transplant. But if you are not, then that is an early transplant. And the next question is about you have a best response, you have certain response to the first transplant, and then what to do with the second transplant, right? So that used to be the case in European studies. If you look at it, they did the 2 transplant study versus single transplant, and the people who really benefited were the one who had not a very great response to the first transplant, a less than very good partial response. Means if your response is less than very good partial response, then you can benefit with the second transplant. Now we have a lot of great drugs, including the 4 drugs now coming up, and then you are able to achieve a very good partial response even before the first transplant. So you're likely to get that response after the first transplant. So the question is, do we really need to do that transplant at the second time? Now, that question is still open, but right now the whole the second transplant question is mainly focused on whether the risk, how high risk your disease is, right from the diagnosis. And that is driven by that rather than the response. So I don't know, it depends on the center to center, but at least in our center, we don't do a second transplant because of the US data showing that the second transplant versus single transplant has no difference in the outcome. But I would like to see what other centers and my colleagues do. So in both the cases, we just do single transplant and go from there.
I would, so I echo everything Dr. DeCall said. I think, you know, so he's talking about tandem transplants. Tandem transplants are not used that much, and that's when the second transplant's done within 6 months of the first, typically. One thing that I think, I bet you everybody here would agree upon, I think second transplants are years out or sometimes forgotten as a very good method to get somebody back into a good control with their myeloma. Sometimes there are people who are struggling with all sorts of drugs and people are like, well, you know, that transplant, but I think we've all had the experience of doing a second transplant for somebody and getting them under much better control, and then they can go on and do other therapies again. So there's been a couple of publications now that show, unfortunately, a lot of those collections that are stored for a rainy day don't get used, and I think there are times when actually that should be considered.
I agree with that fully. At our center, only about 30% of patients who have a second bag of stem cells in the freezer end up ever using it. You know, and I think a lot of patients and also clinicians are dissuaded from a second transplant because they, you know, the question they ask is actually not really the right question. You know, the question should not be, how does a second transplant stack up to a first transplant? It's not as good, especially, you know, if you're using it as fourth line therapy or fifth line therapy, it's not going to be as good as the transplant you used as part of first line therapy. But the right question is, how does it stack up compared to the other therapies available for that patient right then? And oftentimes, when the response rates to the approved agents in that setting may be 20%, 25%, transplant actually has a higher likelihood of inducing a response with a shorter duration of therapy and a shorter period of real cytopenias than some of those other therapies. So I agree that it is underutilized in relapse disease.
Okay, great. Thank you for those responses. A couple follow-up stem cell transplant questions. Well, Patrick made a comment that he had a stem cell transplant that had a 6-month remission, but he's lived 17 years. So just because transplant doesn't work doesn't necessarily mean you won't have a good outcome with myeloma. And then second question is from Nancy, are allotransplants still thought to be a possible cure?
So I can take this question. So you know, allotransplant has this aura of possible cure because in other cancers like leukemia and some lymphomas has been curative. And that was really the premise on how this was first pursued. The reality is, while there might be some patients that get cured with allogeneic transplant, they are few. And there are actually patients who are, for all practical purposes, also cured with intense therapy, including autologous transplant. We recently had the chance to essentially use individual patient data and put together, you know, 4 large trials that were designed, you know, 10 to 15 years ago, randomizing patients between the double auto versus auto and allo. And bottom line is, after 10 years, there is a slight advantage to allogeneic transplant. What is impossible to tell is how applicable that is to this day and age. Because therapies have improved so much in this meantime. So I think the greater consensus today is allo might still be adequate for some patients in the setting of a clinical trial. And it's certainly not a mainstream therapy. And I would say it's a therapy that probably shouldn't be performed in most cases outside a clinical trial. Okay. We'll be curious to see what Natalie or Abhinad or Dr. Zander think?
So at our center, actually we do quite a bit of allo. We have been doing that. Probably the trend is going to probably slowly change given the fact that now we have a lot of new trials with the CAR T therapy and all those stuff coming up, and that would probably, hopefully, would be a better option. But so we try to do it under clinical trial, but unfortunately there are not a lot of trials for allo transplant. And so if somebody is a high risk and much young patient, like somebody, as I said, I saw a patient, a 35-year-old lady with a 17p deletion myeloma, then definitely I would discuss that an option. And I myself don't do allo, but I would send to one of my colleagues who do allo and then have them have a discussion of risk and benefits. There is definitely a potential for cure, but that comes up with, other stuff of the graft versus host disease, treatment-related mortality. And so it's good to get a opinion in a center who does a lot of this modality, because not a lot of centers do allo. So I always tell my patient to go to see a specialist who had the experience of doing all of the, a lot of them.
I would just add that I think this is one of the more contentious areas in multiple myeloma. There are people who feel strongly both ways about this. And what ends up making it a little bit difficult is that since very few allogeneic transplants are done, most people can say, well, I can remember the person who's done great, or I can remember the person who did terrible. And I would underscore what Dr. DeCall said. Unfortunately, the most recent national trial had to close prematurely, so we don't have any real answers. And Dr. Costa is right on the money, saying the data that he was looking at is almost 20 years old now in terms of whether it would really have an advantage or not. I personally would actually like to see another allo study come out again, because I think that there are those patients. I think the problem is going to be trying to figure out who's the right group and what's the right preparative regimen, and whether the competitor is going to end up being a CAR T, for example. I think there's still, it is unclear why, as Dr. Costa said, an allo doesn't work as well for myeloma as it clearly does for leukemia, where we can say after a couple of years, your disease is very unlikely to come back. In myeloma, we all know that you can have an allo and you can relapse at year 3 or 4 or 5 or 6. But I still think it's a question that we don't have a decisive answer on in the long run.
I have another question here, 2 questions, one from Diana, one from an anonymous attendee, and these are questions we get a lot. Diana was diagnosed with MGUS at age 54, and at her 69th birthday, the Damocles sword fell and she became symptomatic, stage 1, and currently taking Revlimid and RVD. Her mother was diagnosed with non-secretory myeloma at age 82 and expired within 22 months. Based on family history, would you recommend an oncology consult and screening for her siblings and daughter? And we also had an individual from their family diagnosed with myeloma.
Well, I think there's actually starting to be some efforts in the country to look at things like this. A number of years ago, there was a study done in France where they were looking at families that had more than one family member or first-degree relative with myeloma. And one thing that came out from that study is that they could potentially find some mutations within families, but they really couldn't find the thing. They were hoping that it might be a situation, say, for example, like breast cancer, where there is a mutation called BRCA1 or BRCA2, which gives you a relatively high risk of having breast cancer in a relative. So there really hasn't been that kind of smoking gun yet in multiple myeloma, but I think there are studies underway. There are a couple of things. There's something called PTARG7 that people have looked at. There is ETV6 that can be shown sometimes in families to be involved. But I think Mayo is doing this. I know that I think Irene Gobriel has headed up a study as well. And so I hope we learn more in the future, but I think they should look around. I think that there are people that would be interested in testing their family. They may not be able to give them an answer, but I think that we're trying to learn more, because there clearly are some families that have a tendency for this to happen.
Jenny?
Okay. Let's let's talk about, well, a quick question about MRD. There's so many questions, it's so hard to know which ones to ask. And a lot of these are for, yeah, it's just tough to be able to pick. So I would say there were some questions about light chains. We have a class in HealthTree about light chains, and we will be recording this. So Dr. Callender addressed that. So I would say some of those questions can be addressed in terms of that. Another question that I think is an interesting question is about minimal residual disease, and there's a bone marrow biopsy test, clonoSEQ, there's a blood-based test being developed. I think that'll be our last question, and then we'll go to a 10-minute discussion, a little bit about HealthTree, and then we'll start our second session. So we can gather these up and send some of the questions to the doctors for you, and then try to get a response back for you, because we have so many. We've answered 40 questions so far, but we still have 50 open questions, and it's just hard because we're running low on time. So we apologize. But do you want to? Does somebody want to address MRD testing in general, and that particular test in specific?
I can comment on those. So there are essentially two types of MRD tests, one based on flow cytometry, the one based on genetic sequences that are unique to that person's myeloma. The one based on the genetic sequence called clonoSEQ, that's the only one that has been endorsed by the FDA because it has a rigorous analytic validation. There's the flow cytometer. There's one particular test. It's called NGF that was developed by a consortium called Euroflow that has this very excellent performance, very close to the genetic-based test, but is only available in a few sites in the United States. There is a very powerful test to give prognostic information. Just like we do chromosome analysis early on for prognostic information, MRD post-therapy gives you the very powerful prognostication. What is still unclear is how we should use that test to adapt therapy. There are several studies addressing this question right now. We should know the answer in the next few years. Sometimes I do use outside clinical trials, particularly in patients who have been on maintenance for a period of time and are having side effects or considering stopping. And I think we have pretty good data that the risk of progression is somewhat dependent on the residual burden of disease. Sometimes I use the test to guide that information. Of course, all the MRD tests that have been developed are bone marrow based. Those tests don't have the same performance in the blood. The fact that they can be done in the blood doesn't mean they should be done in the blood. There's some interest of developing other tests that are protein-based, something like called mass spectrometry, that detects essentially the M spike at a very, very minuscule level. But we don't yet have adequate cross-validation on how they relate to bone marrow through MRD based on the disease burden. Again, there's some very nice correlations coming up. I think in the future they might be used, for example, to indicate what's the right time to do the bone marrow, to look for MRD in the bone marrow. Because in theory, while we still have the protein in the blood, we probably might not need to do the bone marrow test.
Mm-hmm. Okay, great. That's an exciting area. I think people would like to get away from bone marrow biopsies if they can. Mm-hmm. Well, we would like to just thank you so much, Dr. DeCall, Dr. Costa, Dr. Callender. We are so grateful that you joined this first session with us. As you can see, there's so much to talk about with myeloma, and the time goes by so quickly. It's shocking, actually, that we're able to cover as much as you did, but also not able to cover everything we want to.